Special welcome to our two guest speakers, Professor Lucille Blumberg and Dr. Azwi Takalani. And I also want to acknowledge the presence of our Dean, if he's here, Professor Vinny Naidu, and our two Deputy Deans, Professor Marinda Oseazen and Professor Dietmar Olem. So we don't have a lot of time because I expect that there will be quite a few questions. So I will start first by reading the short bio of Professor Lucille and Dr. Azwi, and thereafter I will allow them to give their presentations, and hopefully then there will be enough time to answer questions that will emanate from the meeting. So I will quickly read now the short biography of Dr. Azwi Takalani. Dr. Takalani is a medical doctor and fellow of the College of Public Health Medicine of South Africa. She has a Master of Medicine in Community Health. She's currently working as a medical monitor and safety physician with the HIV vaccine trial network and COVID-19 prevention network operations in sub-Saharan Africa. The HVTN, which is the HIV vaccine trial network, conducts all phases of clinical trials, from evaluating experimental vaccines for safety and immunogenicity to testing vaccine efficacy. The CoVPN, which is the COVID-19 prevention network, conducts phase 3 efficacy trials for COVID-19 vaccines and monoclonal antibodies. In this role, she has been involved in clinical trials from protocol to clinical research site development and ongoing safety monitoring of trials throughout sub-Saharan and East Africa. You are welcome, Dr. Takalani, and thank you for accepting our invitation on short notice to come to this session. And then I will quickly then read Professor Lucille Blumberg bio. Professor Lucille Blumberg is a Deputy Director at the National Institute for Communicable Diseases of the National Health Laboratory Service and founding head of the Division of Public Health Surveillance and Response. She has worked on a large number of communicable diseases outbreaks, including COVID-19, influenza A, H1N1, Rift Valley fever, polio, measles, rabies, avian influenza, cholera, typhoid, and the new Lujo virus. She's currently a medical consultant to the Division for Outbreak Preparedness and Response, and also medical consultant to the Center for Emerging Zoonotic and Parasitic Diseases, where her major focus is on malaria, rabies, viral hemorrhagic fevers, and zoonotic diseases and tropical and travel-related infections. She's a medical graduate of the University of Witwatersrand and a professor in the Department of Medical Microbiology at the University of Stellenbosch. And she holds a position in the Department of Veterinary Tropical Diseases, the department that I'm currently heading. And we're also proud to have her in the department because she brings in a lot of value and also that motherly love. I don't know how many of you have traveled with Lucille, but she will feed you. She has a specialist qualification in clinical microbiology, travel medicine, and infectious diseases, and she was awarded an honorary doctorate of science in medicine by Vets in 2022. Special welcome again to you, Lucille, and thank you for also accepting our invitation. So I think we can start now the fun part of the session. So I will hand over to you and Dr. Takalani.
So thanks very much, Dr. Matjila. It's really such a pleasure to be here. Actually, my week has been spent responding to a rabies outbreak in both city of Cape Town and the cradle of mankind. So definitely a One Health week. I'm going to hand over to Azwi to start off the presentation. Thanks, Azwi.
Great. Good morning, everyone. I'm just going to share my video briefly so you can see my face and then go off to save some bandwidth. So let me find the slides and put those on. Okay, that's not the slides. Can you see my slides?
Yes.
Okay, great. Thank you very much for having me to give this talk with Professor Blumberg, quite an honor. I just want to quickly go through an overview of COVID-19 vaccines. I think I have been introduced well, so I won't introduce myself again, except to just reiterate that I do work on COVID-19 vaccine trials. And some of these trials are sponsored by industry, although I do not draw direct remuneration from industry, but just to state it up front. So in my talk, really leading up to the questions, which is going to be, my talk is going to be very brief. I just want to touch on, the aim of a vaccine or what the benefits of a vaccine would be, how vaccines work, the type of vaccines that are available, why we were able to develop them so quickly, and finally, how safe these vaccines are. And so when we talk about COVID-19 vaccines, or vaccines in general, what we're trying to do with vaccinating people is to derive a dual benefit to the individual as well as benefit to the community overall. In terms of individual benefit, we're trying to reduce the severity of illness, so to prevent people who will have severe COVID infection and who may end up being hospitalized in critical care or dying. And also just to prevent infection in general, although most of our vaccines are not targeted for general infection prevention. And in terms of the other benefit that we derive, which is really very important, is benefit to the community. So we do not talk much about herd immunity as much as in the beginning of the pandemic, because there was a lot of misinformation about how natural infection will lead us to herd immunity, certain vaccines will lead us to herd immunity. But the general principle, holds that we are trying to benefit the community through reducing transmission within the community and having healthier communities, but most of all, decreasing the stress on health systems. As you know, once we have a surge of infections, then we have many people seeking hospital care. Some of them are unable to get appropriate care for their COVID infection, but also another adverse impact is that other people who have other medical conditions may not be cared for appropriately. So in the development of the COVID vaccine, the main target here is the spike protein. So I wanted to show you this picture. The spike, this is a SARS-CoV virus, if I can use my pointer, SARS-CoV-2 virus, and it has these spike proteins on the outside of it. And these proteins are the ones that go and attach to the transmembrane ACE2 protein, and they enter the cell and thereby cause infection. And the spike protein is the main target for most of these COVID vaccines that have been developed. So in general, a vaccine, any vaccine, works by mimicking what the immune system would ordinarily do. And so the presentation of the antigen via the vaccine will allow the body to recognize the spike protein, develop antibodies or produce antibodies against it, so that when you are actually presented with the actual vaccine, you already have antibody and T-cellular response against the virus. So I'm just going to try and play the video and see if it will work. It's a nice illustration of how the vaccines go on to prevent infection. So it's a quick video. So there we have the receptors on the cell, which is a transmembrane protein. Then you formed antibodies. They go and block off the receptors so that when the vaccine comes along, it cannot attach and prevents infection. And that's primarily what we are striving for. So I've already mentioned that the main vaccine antigen is the spike protein, and I'm just going to move on to showing you the different types of vaccines, COVID-19 vaccines that are available. So I'll mainly touch on the ones that are currently available in South Africa, of which the first one is the nucleic acid, mainly the messenger RNA vaccines. And this is like the Pfizer vaccine. And basically here the messenger RNA goes into the cell and stimulates the cell to the human cell to produce antibodies towards the spike protein. And then the second one that we have available is the J&J vaccine, which is a viral vector. And here we have a chemically weakened virus. So that's the Ad26 virus, so the viral vector, not the COVID virus, where the spike protein or the antigen is inserted therein, and then the viral vector allows for the spike protein or synthetic spike protein material to be introduced into the cell and thereby stimulate an immune response. So if we were to think of COVID as the full sandwich, and looking at some of the different vaccine types that we've shown, we can realize that it is not possible for the vaccine to actually give you or lead to you having COVID-19, which is one of the myths that are circulating. So if we look at the mRNA vaccines, these are like a recipe, right, for the sandwich. They go in and they tell the cell to stimulate a certain immune response. So with a recipe, you do not have a sandwich. And so if you look at the vectors, which is similar to the J&J vaccine, so it's like the bread that you would use to hold the filling of the sandwich. So you essentially just have a cover and then you introduce using the bread. So obviously that would also not give you the actual infection. And so if you look at an example such as the Novavax virus, these are more looking at things like adjuvants. So I think it's important because one of the myths that are going around is that COVID vaccination leads to people developing COVID-19 or being infected. And I think in the Q&A we can unpack that a little bit more. Now, in terms of how was it possible that we developed a COVID-19 vaccine, a process that usually takes close to 10 years, in 10 months or to a year? And I think the answers are that, and are the vaccines really still experimental? And I think the answer to that is that no, the vaccines are not still experimental. We were able to develop these vaccines because we did not start from zero. So there are different platforms or technologies that were used in order to create the COVID-19 vaccines. And these platforms were gleaned from different disease areas. So for example, if you think of the Janssen vaccine, that Ad26 vector is being used for the Ebola vaccine. And so it goes. So we build on information and technology that was already existing, and all the scientific world virtually halted a lot of what they were doing to come and everyone who was involved in vaccines to come and focus on doing COVID-19 vaccinations. So we brought the wealth of our information together in order to expedite the production of these vaccines. So also it takes 10 years or close to 10 years because ordinarily when we develop vaccines, we go through the serial pattern of phase 1, phase 2, and go sequentially. However, because this was an international pandemic and in everybody's interest for us to control the pandemic, every governments and pharmaceuticals were willing to invest in the second phase or the subsequent phase of clinical trials before the first one was completed. And as soon as the first one was completed and it showed that we could proceed, we went ahead to the second phase. We didn't have to wait to seek funding to develop the vaccines. And that money that could actually be counted as wasted was actually nothing in comparison to how economies and our lives had been brought to their knees. So if you think about it, we started off with more than 36 vaccines in phase 1 of trials. And today we only have about 4 or so under EUA and Pfizer now being fully registered just in the previous week. So we did not cut any corners. It was just about coming together and doing a parallel instead of sequential development. And finally, all our regulatory authorities worked with us in order to ensure that vaccines were developed in time. So if we take our own CEPRA, for example, it usually takes a while for them to vet a protocol and then approve it. But what they did is that they had a special committee that was going to focus actually on just reviewing the vaccine, any COVID vaccine or therapeutic protocols in order to make sure that they could actually get these trials started more quicker. So no corners were cut, more resources were put in, and we all pulled our efforts in order to make sure that we got to this phase much quicker than we would ordinarily. And so in terms of questions about are the vaccines safe, I think the first thing maybe to mention is that now billions of doses of various COVID-19 vaccines have been administered all throughout the world. And we still have the same message that the most common side effects that people will experience are really the self-limiting reactogenicity symptoms that are experienced within the first 3 to 5 days or up to 7 days. And the vast majority of side effects the vast majority of side effects fall within this category, and everything else, and I'll speak to it later, are really rare side effects which should not be stopping us really from continuing with the rollout of vaccinations. I think I've already spoken to how mRNA vaccines do not change the DNA, and I just wanted to touch on a few things relating to vaccine safety and if we should not vaccinate if we have certain conditions. And the first one was, what if you have a history of severe allergic reactions? Should you not vaccinate? And the answer to this is that you should be vaccinated, but if you have severe allergic reactions to a vaccine, it's probably best to go to a bigger vaccination center, where you can also be observed for a little bit longer than the 15 minutes. And should you have a reaction, then there is staff at hand to actually manage your reaction. I need to say though, all these guidelines, which are a feature of all vaccination protocols around the world, were anecdotal to say we think this is good practice. And what we have noted so far, there's a study that just came out that actually these people who are usually earmarked and thought that they would have severe reactions to the vaccine haven't. And in fact, someone did an economic analysis to say, if you think about this extra time that we are watching these people and staff members waiting on hand, it actually seems to even be a bit of an overkill to actually continue with this recommendation. But it remains a feature of most vaccine programs all throughout the globe. And what about people who have underlying medical conditions and at risk for underlying medical conditions? These people are actually at risk for severe COVID-19 disease. So the vaccine should be prioritized, and a feature of most vaccination rollout programs is that these people are prioritized because should they develop COVID, the consequences of having COVID may be devastating to them. And we have seen, what about immunocompromised people? And in this country, we have high numbers of HIV, people with HIV infection. And I think that also recently the FDA has now authorized this additional boost for people who have immunocompromised states, and basically saying that the immune response may not be as good as someone who is not immunocompromised. So being immunocompromised is not a reason not to vaccinate, although if you are acutely ill, that may be a reason to delay vaccination until you are really no longer ill. And then I just wanted to touch on this when people are saying, well, we started these programs vaccinating people, and only halfway through we discovered that, there may be related Guillain-Barré syndrome, Bell's palsies, myocarditis. And just to say that these are very, very rare side effects. And these are, as long as we are aware of them, and when we start to experience them, we present for care, then these can be well managed and should not be fatal, which is actually quite the contrary. COVID-19 infection itself can be fatal. So these are rare side effects that they could not be picked up when already hundreds of thousands and few millions of vaccines had been given, and are only coming to the fore now that vaccines have been administered in multiple millions and into the billions of doses. And the final one I wanted to touch on was pregnancy. Is it safe for pregnant people to be vaccinated? And yes, it is safe for pregnant people to be vaccinated. In fact, it's recommended that they should be vaccinated because infection with COVID-19 so they are at risk of severe disease, both for them and also poor neonatal outcomes if they get COVID-19 infection. So like I mentioned, many doses have been administered. Many pregnant women have been vaccinated, whether they were aware or not when they got vaccinated, but we haven't been able to pick up any safety signals in these cohorts. And that's why it's deemed safe to vaccinate during pregnancy. And I think that's the end of my slides. A few acknowledgements, and I'll hand over back to Prof.
Thank you very much, Dr. Takalani, for that presentation. I think we will continue with Prof. Lucille's presentation, and thereafter we will allow for questions.
Okay, so thanks very much, and thanks, Azwi. It was an excellent presentation. I think you covered all the important points. I've really just got 2 sentences to say, and then I think we can address the questions. And from previous experience, we know that there are many. So I really want to say that COVID-19 vaccines are safe. They are effective in reducing the risk of hospitalization, severe illness, and death from COVID-19. They save lives, they save livelihoods, they will save our healthcare system, which has been battered by the COVID-19 pandemic. And they will reduce the risks of new variants from developing by reducing the number of viruses circulating. And there really are no contraindications. The risk of COVID outweighs virtually everything. And I'm going to read you just something from one of my patients. She's now an ex-patient because she did get better. She was 51. It happened during the time where the vaccine program was not open to this age group. She developed COVID-19. It was the time of the third wave. The hospitals were completely overwhelmed. She was turned away twice from hospital to be managed on home oxygen. Overnight, her oxygen saturation dropped to the low 60s. It should be well over the 90s. And she was desperate. We managed to get her a bed. She spent 4 weeks in hospital, most of it in ICU, on various oxygen methods of support. And she was finally discharged. And her words were, yesterday, a day short of 2 months, and I nearly stopped breathing. I was told I could get vaccinated. I would never wish ICU and any form of ventilator on anyone. I have so much respect for the medical staff that are machines that never stop working, caring, that need to take care of patients. I wish that the vaccinations for my age group had opened up sooner. I may not have been in ICU, and so many people in my age group may not have passed away over the last few months. That's the message. Go and vaccinate. Protect yourself, protect your family, and protect your community. I think I'm going to hand it back to you, Dr. Matjila, and I think I'm sure there are many questions. I'm happy to start off the questions and just raise some of the issues if that's the way to get things going. I'll ask you how you would like to do it.
Yeah, thank you very much, Lucille. So we will now open up for questions. So if you want to ask a question, just click at the top right of your screen, raise your hand, or you can also type in the chat section. So I will allow for questions as I see the hands come up. Any questions? I think I will start because I've got a question. We've seen that there's been reports of people who have passed away immediately after getting vaccinated, or so is the assumption. And then I would like you to comment on possible vaccine failure, perhaps, and also to comment on the immunity. Once you're vaccinated, how long does the immunity last in vaccinated people?
Okay, so I'll start and then I'll hand over to Azwi. We are vaccinating a lot of people during the third wave. So there's a lot of virus around. And a number of people are infected already or incubating COVID, but not aware of it because many infections are mild or they don't have symptoms. So they go for their vaccine, and then a few days later they present with an illness that is compatible with COVID and they test positive. But they were already incubating COVID. So the vaccine takes at least 3 weeks, for an immune response, and it can't protect something that's you're already infected with. The second thing is in the 3 weeks post-vaccine, and if it's Pfizer, it's the first vaccine. One should obviously get the second vaccine, and then you'll be better protected. You may be exposed to COVID. Many people think because they're vaccinated, they can let their guards down, they can let their masks down, they don't distance, they socialize, they think, well, I'm free now, and they contract COVID during that time. But it's not vaccine failure. It's simply an infection during that period where the immune response is still developing. And we have a number of people who say, I'm vaccinated, I'm going to a party. And really, it's a message that we need to very clearly get across. So it's not vaccine failure. You can't expect the vaccine to protect you during that time. And then there are some breakthroughs. So the vaccine protects best against severe illness, hospitalization, and death. It doesn't protect in everybody against being infected and mostly having mild. Okay.
Lucille, I think we've lost you, or it's just me who cannot hear you anymore.
No, I can't hear her either. But Tshepo, there's a attendee called Magdalene Otto, and she's sharing her screen, and I don't know. Can we maybe ask her to stop sharing? I don't know if.
Yeah, I'm sure she can hear us. Can you please do that? Lucille, do you want to finish what you were saying?
Yeah, can you hear me now?
Yes.
Okay, because another little thing came up, and I'm sure that was somebody else's. Okay, so this is a very common question. We are vaccinating many people, and we have the third wave. So there's a lot of virus circulating, and so people may come to the vaccine for vaccination, but be incubating COVID-19 and not know that. They get vaccinated, and then they present with clinical illness. You know, the vaccine is not going to protect you immediately. It takes at least 3 weeks for the immune response to be elicited. So they are sometimes incubating it. They may be infected in the following weeks post-vaccine, before the immune response is elicited, and you know, they may become ill. So this is not vaccine failure. You know, the vaccine response does take time. And many people think, well, it's okay, I was vaccinated on Friday, I can go to a party on Saturday and let my mask down, I'm okay now. And that's not true. The vaccine is designed to best protect you against severe illness, hospitalization, and death. That is the most important thing. It may not prevent mild illness in everyone. We do see what we call breakthroughs, but there has been a significant drop in severe illness, deaths, hospitalizations in vaccinated people, even older people, even those with comorbidities. As one of my COVID ICU colleagues said, the people in his ICU now are not vaccinated. They're not the vaccinated group. Yeah. So I hope that came out now.
Yeah.
Sorry about that. I don't know what happened.
Yeah, we can still hear you. So I see there's some hands up. Dr. Mora, you can go first, then followed by Ceremonies.
Hi, Lucille, and to your colleague, Dr. Takalani, thanks for the presentation. It's just to speak about more of a comment than a question. I was just wondering if it is correct to use the word breakthrough, because the vaccines were developed with the idea in mind that it would prevent, like you mentioned, severe disease and avoid you going to the hospital. So I was just wondering that a lot of these cases where you know, people are vaccinated and then they acquire the virus and they get sick. Like you said, not everyone will have mild symptoms, but they call it a breakthrough infection, and I think that's, in my opinion, incorrect to use, since the vaccine wasn't developed to prevent infection. I just wanted to have your thoughts on that.
Yeah, perhaps it isn't the best term to use, and I'm sure we can come up with another one, as we may have one. It's not vaccine. You know, I think you have to look at what the vaccine is designed for. It's reduced severity, hospitalization, and death. I think that's reasonable. Thank you.
Yes, thank you. Thank you.
Yeah, I think I do agree, but a lot with COVID, we've become stuck with a lot of terms that we wish we could go back and change. And I think we sort of clung to the term breakthrough infection to try and run away from the term vaccine failure. But like you're pointing out, perhaps breakthrough infection is also still not the most appropriate term, considering what the vaccines were designed for. But it just still seems to be the better of the two terms that are being used interchangeably. I think it's the same with, physical distancing, how we ended up calling it social distancing. And actually at this time, we don't want people to distance socially. We just want them to distance physically, because for mental health, if you distance yourself socially and it's a pandemic, I mean, it could be devastating. But I think it's a good comment. And yeah, it's one of those, stuck between a rock and a hard place and choosing the better of maybe two terms.
Just remember, there's a difference between somebody being vaccinated on the 1st of August and developing an illness and a positive COVID test on the 3rd of August. That is not a breakthrough. They were infected and were incubating the virus at the time of vaccination, and they just didn't know about it. Or they were infected shortly after the vaccination because they went to a party or let their guard down. That's not a breakthrough, and it's not a failure. It's a person failure for the second part.
Questions from Serame, then followed by Joseph. But Darshana, your hand is still up. Is that a follow-up question or is that an old hand?
It's another question, but I'd wait for other people to first ask.
Okay. Thank you. Serame, you can go ahead.
Good day. I'm Serame. My question is about the ingredients in the vaccine, because I see in the social media or people are concerned about the active ingredients in this vaccine. They don't know what is in the vaccine. Some of the social media fake news, they say there's aborted fetus products in the vaccine. And the other question is, why can't the government publish the package insert of the vaccine so that people can know what is in the vaccine, the side effects of the vaccine, the warnings and the precautions of the vaccine? And I just want to, I just saw a little bit, I'm not sure, but I came late, but I saw something about the receptors in the presentation. So I just want to know the mechanism of action of this vaccine. What is the mechanism of action of this vaccine? And my suggestion is that why can't the Department of Health do awareness for how the vaccine works? Because people think once you're vaccinated, you are not going to get COVID and you will never have side effects like these other vaccines that we took previously, because we were not there when they were developed. So now we are here with this one of COVID-19, so we can see everything that is going on here. So I just want to know why the government can't do awareness about pre-vaccination and post-vaccination. Thank you.
So there is a lot of awareness done. There are many reliable websites and information portals that should be used. Unfortunately, there's a lot of disinformation and misinformation on social media, and some of it very sadly from some of my medical colleagues, which really confuses people and causes alarm. And social media is a very loud voice. I think I'm going to leave Azwi to talk about the ingredients and about what's in it. I think we've spoken about how the virus, how the vaccines actually work, and this has been recorded, so you can go back to that. But Azwi, I'm going to hand over to you for some of the other questions.
Thanks, Prof. Yeah, thank you for the question, Serame. I just wanted to start off by saying the ingredients of the vaccine are not being hidden. They're freely available. You can find the ingredients of each vaccine on the National Department of Health website. You can also find them, for example, I'm part of the Sisonke group. You can find them on our Sisonke website. You can find them on the manufacturers' websites as well. So the ingredients are really for public information, And most of these vaccines actually have very few ingredients, about 3 to 4 ingredients in each one. And I think it's, as Prof is saying, there's a lot of misinformation out there, and people intentionally taking knowledge. I don't know how intentional it is, but when we hear some of these myths, we really try to trace back and think, where did this possibly come from? And in terms of the fetal products, for example, most therapeutic agents and most vaccines, not just the COVID vaccines, there are some stem cells that are used to generate certain of these products in the beginning. And now the main message is that there are fetal products within the vaccines, which is actually not true. Some of the myths, it's kind of like difficult to trace where they come from about ingredients. So I've heard like a variety of things, and I'm not too sure where it comes from, but the information about what is actually in the vaccines is readily available, and we can share the sites after this talk if you would want to go in and look. I think Prof did say that we covered the mechanism of action in the talk. And in terms of awareness, I think Prof is absolutely correct. There's a lot of awareness work being done, but I think it's also up to now the general community to be able to choose the correct sources of information and also promulgate the correct information. And when we are all armed with the correct information, this may assist in dispelling some of the misinformation that's actually being promulgated out there. I think it's now beyond just the duty of the National Department of Health, but us as communities, as a scientific world, and as just members of communities to really try and put forth the correct information. Yeah.
Yeah, you're muted.
Sorry about that. We use these things every day and we don't get used to them. Joseph, you can go ahead.
Thank you very much, Tshepo. Mine is more of a comment, which maybe more commenting can also follow. This issue of, I would call it an on goal, where most of, or maybe some of the doctors are actually helping in increasing vaccine hesitancy. Some going to the extent that they tell their patients that I would never get the vaccine. It's better for me to die of any natural infection than for me to be vaccinated. I don't know what the Health Professions Council or whatever is also happening within the medical fraternity.
So I will respond to that. I think it's a shame, it's a disgrace, and it's totally unacceptable. And unfortunately, I don't know what motivates colleagues, some of whom I've known and worked with, to promulgate these terrible, terrible, damaging messages. I will tell you, one of the doctors who did give a message out around against vaccine himself died of COVID just 2 to 3 weeks ago. Yeah, I think, that came as a shock to many people. He had decided against the vaccine for religious reasons, I believe, had seen many patients with COVID and succumbed to COVID. The Health Professionals Council has received numerous complaints about some doctors who have really shared very damaging information, and hopefully they will respond very rapidly to them. It's unacceptable.
Thanks, Lucille. Dashana, then Dr. Smith, and June Peterson.
Yeah, I just have a comment again, and maybe to just get a point of view from Lucille and Dr. Takalani. I know I often hear that on radio and like hearing people speak or just reading about it, they mention that the variants of concern that are currently circulating drive infections. I know it wasn't mentioned in this presentation, but I thought I'd mention it because I think it's a very important point. They say the variants of concern drive the infections, and that's why more people are getting sick. But I think a very important aspect to why there's an increase in infections is human behavior. And I think it's important on this platform and other platforms to mention that and not to solely blame, I don't know if I can put it this way, the virus. Because I think that we don't want to take responsibility for how we behave and how we actually play a role in increasing in infection. So it was just a thought that came to mind because I keep hearing about the variants of concern driving infection, but when I look around, when I walk around, I see how people behave, and I'm thinking, but maybe it's human behavior driving infections. Thank you.
Thanks for the comment, Shannon.
I think it's both. You know, we are quite sociable creatures. We're now 18 months into the pandemic, and I guess people are getting tired of distancing, less socialization, and wearing masks. And you know, for many, COVID has been very, very hard, economically, job losses, family losses, and lots of mental illness. So I think our behavior, you know, obviously has a lot to do with transmission, but let's not forget, Delta is very, very transmissible. There's probably an element of it being airborne, and it certainly has. It's certainly driven the third wave, and we're not sure what is going to, you know, happen with the next wave and what other variants are going to happen, we're going to have to deal with. What we do know is if there's lots of virus around, the chances of getting a new variant are definitely much higher. And that's another role of vaccination, is you may reduce the amount of virus people carry, chances of, perhaps the chances of new variants developing. But, you know, we haven't seen the end of the story yet. It's quite hard to change our behaviors, particularly after 18 months of what we've been through. But absolutely, we have to keep the masks on over the nose, be vaccinated, and go outside. We're blessed with sun, fresh air.
Thanks, Lucille. Dr. Smith, you may go ahead.
Thank you so much. And I just want to say I really appreciated this presentation today. I so wish I had a recording that I could send to a few people. My question is, and you partially answered it now, is sort of where do you see, in your professional opinion, are we going in a year, 2 years' time? In terms of this virus, in terms of the vaccine, is this going to be like the flu vaccine where we go and get it every year? Or is it going to start dying out in a few years' time? Or what do you expect, or what is the community expecting this virus to do?
I wish I had a crystal ball that looks at vaccines and the future. I think there are some knowns and unknowns, you know, that we have to deal with. I think for the immediate time, certainly for the next 6 months, I think the impact, and it's already been seen, the impact of the current vaccines is huge. And it's really changed what we are seeing in our hospitals. Those with comorbidities, those who are older, those who are at risk for severe illness, who've been vaccinated, are protected against hospital admissions and unfavorable outcomes. We don't know what new variants will emerge. Some may not be fit, and some may, you know, not have the advantages of being more transmissible or more causing more severe illness. We don't really know. I think there are a lot of plans, and as we can talk to it more, to look at the vaccines, to look at in the future at some boostering, when we know about the durability of our antibody response, and then look at perhaps the second generation of vaccines, much like we do with flu vaccine, to fit the variant of the season. And perhaps, we'll need an annual vaccine. These are, I think we've learned an enormous amount in 18 months. There's lots of things, that we're still going to learn. But I think where we are at the moment, we really need to apply as best we can, and that's to vaccinate. Azwi, I'm sure you have other things to add.
Thanks, Prof. I think, I just wanted to also touch on the comment that the previous speaker made, that I think, while we should not be combating word for word the messages that are coming out there, an important message that we should be spreading is that although there are variants of concern and some are more transmissible and some are virulent, we have been able to see that vaccines actually are still continuing to provide protection against severe disease and death, even when these various of concerns are coming up. So we need to really be using that opportunity to really promulgate and encourage vaccination. And in terms of boosting, I think what is happening with the pandemic, of course, is that the science has to move very rapidly. Sometimes we see scientific releases in the press before in a peer-reviewed journal. And so there's a lot of information out there that still needs to be consolidated in terms of empiric, objective data, evidence-based data that we can then put into policy as a data-driven decision. So Prof has just mentioned that there is a lot of work happening in the background or plans to really figure out, if you were to boost, what would be the best strategy in terms of, would it be homologous boosting? Would it be heterologous boosting? What would be the time or the time space or the frequency of these boosters? But I think the encouraging information that we have for now is that the people who we've been following, who were part of the very first cohorts in the clinical trials of some of these vaccines, are still showing robust immunity to date, against severe infection and death. They're still showing that they are still protected. But of course, because we don't know which variant of concern may come through, it is important to continue with the booster studies and to come up with empiric evidence. Yeah.
Thanks. Just before I give June Peterson a chance, Dr. Smith, you said that you wish this session was recorded. It is being recorded, and I think Lucille and Takalani would not mind sharing the recording with you. So you can have access to the recording. June?
Good afternoon. In the presentation, reference was made to the vaccine being safe for pregnant women. How else can one allay the fears of pregnant moms? Because I find, especially the younger women, and I have a niece, and they are totally, they're scared, and I'm not quite sure how does one allay these fears, and how do you actually assure them that they will be okay? I don't know. Thanks.
Azwi, over to you.
Okay. So I think, this is a twofold thing. One of the things that we are really learning with the pandemic is that we need to be really transparent about the data. So I do not think that many people know. And in fact, when, it's conversations like this on webinars, it's the first time some people hear the information that millions of pregnant women have been vaccinated and there have been no safety signals that have been detected therein. So I think showing that information to people can go a long way to allaying their fears. And I think the second part of it would be really, people trust the doctors who they go to, the frontline workers, your doctor, your GP, your obstetrician. And I think the message should really be us trying to empower these people with the information and showing them what the data is really talking about, and encouraging maybe your niece, for example, the next time she goes for an antenatal care to maybe engage, with her practicing doctor or her care provider in terms of, what would it mean for me to get the vaccination and would it be safe? I have to say, this goes along with on Sisonke, we saw a few participants who had engaged with their obstetricians, and the obstetricians had said definitely go for it because the risk of getting severe disease is much higher in pregnancy. And because at the time SAPRA had not licensed for us to vaccinate pregnant women, these women were actually hiding the information that they're pregnant to us, getting vaccinated, and only a day later coming back and saying, oh, by the way, I forgot to tell you that I'm pregnant, or I omitted to tell you that I'm pregnant because I really wanted the vaccine. So I think knowledge is power. Let's keep telling people and showing people this data, and more importantly, really empowering our frontline workers who get to engage with the public.
Just to add to that, Azwi, I think we've also shown that COVID can be a very severe illness in the third stage of pregnancy and around the delivery time.
Thanks, Azwi and Lucille. We left with about 5 minutes, but I see we've got 2 more hands, so we may just go a bit over time. I think it's okay because this is a very important session. So, Reboni, you can ask your question and then followed by Dr. Scholz.
Thank you very much, Prof. Matjila, and thank you very much to the presentations. I just want a comment on a more of a policy matter, and my statement goes as follows: that restricted access to vaccine led actually to more people being infected during the third wave, and looking at possible fourth wave coming, if we continue with such restricted access, it might impede our intention of preventing the further spread of the disease. Now, with health being a constitutional right, why is the vaccine not being made available even through GPs, where, like Takalani was saying, people have more confidence with their GPs? Thank you.
Yeah, I think that's a very good point, and I suppose this is maybe the first time we have a respiratory pandemic of this magnitude, and in our responses we've made a lot of mistakes. I think we functioned under some assumptions in the beginning that because we had all seen the devastating effects of COVID, people would sort of like line up for vaccinations, right? So we had this rationing strategy, starting with the people most at risk. But I think that the penny dropped quite quickly, and that's why there's being more access being provided, like the lowering of age groups much quicker than was initially intended. And I think we still have to, on an ongoing basis, be re-strategizing continuously. And you do make a good point that there are other places or other ways of delivering the vaccine that would actually, increase access to the vaccine. And it's really up to us to continue lobbying the National Department of Health and, really putting out the data that shows that there's restricted access. I saw an HSRC survey that just came out, which was actually clearly pointing to that some of the poor uptake is due to access, and it's information, scientific evidence like that will push for guided or more deliberations within our rollout strategy. but I think you do make very important points that some uptake is due to restricted access indeed.
Thank you. Dr. Scholz, you may go ahead.
Hi, good afternoon. I did join the meeting late, so I apologize if this question has already been raised. I just wanted to get your insight into sort of a news item. So I'll just read this little section here. It says, recently the director of the evidence-based medicine consultancy, Dr. Tess Laurie, wrote to the UK Medicines and Healthcare Products Regulatory Agency with concerns about what appeared to be accumulating adverse event data. For example, Dr. Laurie raises the awareness that between January 4th and May 26, 2021, a total of 1,250 deaths and 888,000 adverse events reported, which are not obviously directly proven as correlated with the vaccine process, but certainly could be so. And I see that in that letter that she writes to them, she has stated that there's now enough evidence to declare the vaccine unsafe, and that preparation should be made to ameliorate the medium to longer term adverse events as well. What are your thoughts on this?
So I don't know
Okay.
who this lady is. I don't know what this organization is. There are many similar organizations. Some of them absolutely just misinterpret the data. Every adverse event, particularly a serious adverse event, and Azwi is part of this, is investigated. When they report deaths following the vaccine, you will find that it's somebody's underlying condition that might have been the cause. If it's COVID, they might have been incubating it at the time of vaccine. So, this kind of very broad, information that was shared by this woman needs itself to be interrogated. I can tell you, I run a hospital data system for COVID called DATCOV. We have almost 300,000 patients on our data list. Most of them were not vaccinated. Okay, most of them were before this current wave, before the vaccine program was rolled out. I think there is no doubt that the vaccine is safe. It protects against severe disease, and it's this kind of misinformation that we need to speak out against. Azwi, I'm sure you've got lots to add there.
Yes, I do, but I'll make it brief. I think Prof is absolutely right. There's a lot of misinformation. There's people who actually take data that is being reported out of context and present it as information for anti-vaccine purposes. So I think that the first thing would be to say these are large vaccination programs internationally. We've never vaccinated this number of people in a short space of time in history. And therefore, there is a lingering thinking that people will associate temporality and say this is what has caused the adverse event. And I think it's human nature, it's like if you have a deep loss and then you have a health effect, people are more likely to say, I developed this cancer because my mom died 2 months ago. And we see a lot of that sort of association due to temporality and not necessarily biological plausibility or feasibility. So one of the things that we continue to do is, as Prof has mentioned, we investigate each serious adverse event, we investigate each death, and we try to really come up to the underlying cause of death. And we haven't seen, except for the thrombocytopenia with thrombosis syndrome, maybe Guillain-Barré syndromes, we haven't seen any other concerning patterns or safety signals, if I had to mention it like that. And one of the ways that you detect a safety signal is by comparing what is observed against what is expected. So if you really look at what is the expected rate of myocardial infarctions in this country? And then you compare it to what are you observing post-vaccination. As long as the two are coming across to be similar or at a similar rate, no statistical significance, then there's really no need to worry. And I think if we unpack this report, we would actually see that these adverse events that are being labeled to be astronomical, they are within the expected rates of the conditions that are actually being reported. And just because we say it's an adverse event, we just mean that it occurred post-vaccination. We are not necessarily inferring causality in terms of that. And I think it's an interesting comment to say that there are long-term side effects, and not describe what those long-term side effects are. And how do you even know these long-term side effects? Because people haven't been vaccinated for that long in order for us to pinpoint this. And the cohorts that we are following from phase 1 trials have not started displaying these side effects. So I think it's a matter of really, with all the information that we read, and sometimes even as we are crying out for healthcare practitioners to practice good medicine and only promulgate evidence-based information, that is not the case. Like Prof said, some colleagues are really promulgating misinformation, and similarly, it's the same with journalism. Sometimes you know that a story can sell, although it may not necessarily be the most factual. And so these stories have a tendency to rise up in publications, and may not necessarily be true because they are published in a media source. So I think, again, about looking at reliable sources of information.
Thanks, Azwi. We've gone above time, but I see there's one more question. So this will be the last question. Then I will allow our guest presenters to have the final word, and also check with my boss, Prof. Naidu, if he also doesn't want to have a final word. Otherwise, I might be in trouble and lose my job. So, Julia, you can go ahead.
Good afternoon, everyone, and thank you so much for this session. So my question is with regards to the Lucille mentioned that some of the stories and myths about people dying from the vaccine might be due to the incubation. They might be incubating the virus beforehand. So my question is, then how do we go about addressing that if you are like perhaps someone who has minimal to no symptoms? They might not know that they have the virus. So how do we go about that? Does that mean that they have to test beforehand before actually going to get the vaccine?
No, so most people, I think you just need to put this in perspective. They get vaccinated, they may develop COVID. Very few people would die. We're not saying they're dying post-COVID vaccine or dying from COVID. They can die from another cause, but there are very few of them where that timing will happen. So we're not testing people. I think what the important message is, if you happen to be incubating COVID at the time, and then you're vaccinated and you present with COVID afterwards, hopefully it will be mild and we will manage you as a COVID illness. Most are mild. If you've got underlying risk factors, we will manage you and monitor you for progression to severe illness. But we're not testing everybody. You may not pick it up during an incubation period. If you have any symptoms when your vaccination time is due, you should perhaps just delay your vaccine until you're feeling better. Otherwise, you're going to get this mix-up. The important thing is to remember that if you're vaccinated, you still need to maintain those non-pharmaceutical interventions, the masking, the distancing, trying to be outside in fresh air, and similar.
Thanks for the response, Lucille. So I think we've come to the end of the session. Vinny, is there anything that you'd like to say before we close?
Just to thank the presenters for a very informative talk. And as a pharmacologist with this background, I think it puts into perspective how much of fear there is over well-recognized technology. Thank you very much.
Thanks, Vinny. You may have the last word, Azwi or Lucille, if there's any additional messages that you want to leave with the group.
So I'll go first so that Lucille can have the last word. So I just really want to encourage people to go out there, vaccinate. That's the only way that our health system will go back to normal. Our economies will be revived, our livelihoods restored, and so we can just interact like we used to before. But most importantly, when you have been vaccinated, please remember that non-pharmaceutical interventions are still necessary until we really get on top of this pandemic and we have enough people maybe vaccinated. Yeah, I think that's my takeaway message. Vaccines are safe. Let's go out there and vaccinate.
Thanks, Azwi. Lucille?
I'm just going to say I have the same sentiments. I echo those. I couldn't have said it better. Thank you, Azwi.
Yeah. All right. So we've come to an end. Thank you so much, Lucille and Azwi, for taking the time to come and share these important messages with us. And also thank you for the colleagues for attending. I also see that there's people from outside the university. Thank you so much for making time to come and attend this important session. So with that, I would like to then end the session. Thank you all and be safe. Keep yourself and your family from getting infected. Go and get vaccinated and enjoy your weekend. Thank you very much.
Thank you. Thanks very much, Tshepo.